into the duodenum that break down protein, fats, and carbohydrates. The pancreas also makes insulin, passing it directly in the bloodstream, and the insulin, as we all know that this is the chief hormone in our body for metabolizing sugar. Next slide, please. So next to the pancreas is we have the liver. The liver produces bile, which is stored in the gallbladder. Bile is important in the digestion of fats and is deposited into the small intestine when the gallbladder is stimulated to contract by the presence of fat. So the liver has many functions, but its main job within the digestive system is to process the nutrients absorbed from the small intestine. So bile from the liver secreted into the small intestine also plays an important role in digesting fat and some vitamins. And the liver in our body is a factory. So it takes raw materials absorbed by the intestine and makes all the various chemicals our body needs to function. And the liver also detoxifies potentially harmful chemicals. So it breaks down and secretes many drugs that can be toxic to our body. Next slide, please. Releases it into the duodenum in the small intestine to help absorb and digest fat. Next slide. Okay, so we have now the large intestine. The large intestine, which is responsible for excreting any waste products that are in the GI system. And the excretion occurs through the rectum, and this is an activity that one learns to control. So the large intestine or colon is responsible for processing waste so that emptying the bowel is easy and convenient. It is a 6 feet long muscular tube that connects the small intestine to the rectum. So as what we can see in the illustration, the large intestine is made up of the cecum, the ascending colon, the transverse colon, and the descending colon, and the sigmoid colon, which connects to the rectum. So stool or waste left over from the digestive process is passed through the colon by means of peristalsis, first in a liquid state and ultimately into a solid form. And as the stool passes through the colon, water is removed. Stool is stored in the sigmoid or the S-shaped colon until a mass movement empties it into the rectum once or twice a day. And it normally takes about 36 hours for stool to get through the colon. And the stool itself is mostly food, debris, and bacteria. And these good bacteria perform several useful functions such as synthesizing various vitamins, processing waste products, and food particles, and protecting against harmful bacteria. So when the descending colon becomes full of stool or feces, it empties its content into the rectum to begin the process of elimination or a bowel movement. Then, the rectum, this is a straight 8 inches chamber that connects the colon to the anus. And the rectum's job is to receive the stool from the colon. And it lets us know that there is stool to be evacuated and to hold the stool until evacuation happens. So when anything like gas or stool comes into the rectum, the sensor sends a message to the brain, and the brain then decides if the rectal contents can be released or not. And we have the anus. The anus is the last part of the digestive tract. So it is a 2 inches long canal consisting of the pelvic floor muscles and the two anal sphincters. We have the internal and the external sphincters. So the lining of the upper anus is able to detect the rectal contents. So it lets us know if whether the contents are liquid, gas, or solid. And the internal sphincter, this is always tight except when stool enters the rectum. So this keeps the continent or prevents us from pooping involuntarily when we are asleep or otherwise unaware of the presence of presence of stool rather. So and the when we get an urge to go to the bathroom, We rely on our external sphincter to hold the stool until reaching a toilet where it then relaxes and to release the contents. Next slide, please. So now let's move on to the layers of the GI tract. We have our mucosa, our muscularis mucosa, the nerve plexus, which is a network of nerve fibers running through the wall of the GI tract that allows local reflexes and control. And we have the adventitia. So this is the illustration of the layers of the gastrointestinal tract. Next slide, please. So we have the mucosa layer. The mucosa layer provides the inner lining of the GI tract. It can be seen in the mouth and is consistent throughout the tube. And this layer has epithelial component and a connective tissue component. So the mucosa, this is the innermost layer and its function is for absorption and secretion. It is composed of epithelium cells and a thin connective tissues. The mucosa contains specialized goblet cells that secrete sticky mucus throughout the GI tract. Next slide, please. Then we have the muscularis mucosa layer. The muscularis mucosa layer is made up of muscles. Most of the GI tract has two muscle layers. One layer runs through circularly around the tube, helping keep the tube open and squeezing the tube to aid digestion and motility. And the other layer, it runs horizontally, which helps propel the GI contents down the tract. And the stomach has a third layer of muscles, which run obliquely and gives the stomach the ability to move contents in a churning motion. So the muscularis mucosa, this is a thin layer of smooth muscles that support the mucosa and provides it with the ability to move and fold. And the submucosa is a thick connective tissue layer that contains the arteries, the veins, the lymphatics, and the nerves. Next slide, please. Now we have the nerve plexus layer. The nerve plexus has two layers of nerves. One is the submucosal layer and the mentoric layer. And these nerves allows the GI tract local control over movements, secretions, and digestion. The nerves respond to local stimuli and acts on the contents of the GI tract accordingly. And the GI tract is also innervated by the sympathetic and parasympathetic nervous system. The digestive nerve flexes intricate layers of nervous tissue that control movements in the esophagus, the stomach, and in the intestine. And the two major nerve centers that are involved are the mentoric flexus and the submucous flexus. The mentoric flexus is situated between the circular muscle layer and the longitudinal muscle layer in the lower esophagus, stomach, and intestine, while the submucosal layer, as its name implies, it is located in the submucosal tissue, which connects the surface mucous membrane lining in the deeper muscle layers in the stomach and intestine. And the function of the mentoric flexus, it receives its messages from the vagus nerve and responds by transmitting the message to the muscle cells, which are thereby activated to contract. Control of nerve impulses is involuntary. The muscles of the stomach and intestines play an active role in digestion as waves of muscles contractions or the peristaltic waves push food through the parts of the digestive tract. It is thought that the mentoric flexus stimulates the muscles to contract in peristaltic waves and it helps keep muscle tone throughout the intestinal walls, promote secretions of intestinal juices, and allow muscular constrictions or the sphincters to open, and thus permitting food to pass from the one part of the digestive system to another. While the function of the submucosal layer is not clearly defined. In the stomach, its role may be partly inhibitory, working against the mentoric flexus to control the muscular contractions more finely. In the intestine, it is generally believed to work in accord with the mentoric flexus in producing peristaltic waves and increasing digestive secretions. Next slide, please. So for the last layer, we have the Adventitia layer. The Adventitia is the outer layer of the GI tract. It serves as a supportive layer and helps the tube maintain its shape and position. The Adventitia, this is the final layers. So these are made of loose connective tissue and coated in the mucus so as to prevent any friction damage from the intestine rubbing against tissue. And It also carries blood, vessels, and nerves to the wall of the digestive tube. Next slide, please. Okay, so la- after the layers of the GI tract, we have the gastrointestinal activities. So there are four major activities of GI system. We have the secretion of enzymes, acid, bicarbonate, and mucose. We have the absorption of water and almost all the essential nutrients needed by the body. We have the digestion of food into usable and absorbable components, and the motility or movement of foods and secretions through the system, and what is not used is secreted in the form of feces. Next slide, please. So first is the secretion. The GI tract secretes various compounds to aid the movement of the food bolus through the GI tube to protect the inner layer of the GI tract from injury and to facilitate the digestion and absorption of nutrients. Secretion begins in the mouth, and the saliva, which contains water and digestive enzymes, is secreted from the salivary glands to begin the digestive process and to facilitate swallowing by making the bolus slippery. And the mucus is also produced in the mouth to protect the epithelial lining and to aid in swallowing. Next slide, please. Okay, so the esophagus also produces mucus to protect the inner lining of the GI tract and to further facilitate the movement of the bolus down the tube. And the stomach produces acid and digestive enzymes. In the stomach, secretion begins with what is called the cephalic phase of digestion. So, what is cephalic phase of digestion? This is the stage in which the stomach responds to the mere sight, smell, taste, or thought of food. So once the bolus arrives at the stomach, gastrin is secreted by gastrin cells, and this is one of the stimulators of acid release. So gastrin helps the pancreas produce enzymes for digestion and helps the liver produce bile. It is also stimulates the intestines to help move food through the digestive tract. Next slide, please. Okay, the gastric chief cells will release pepsinogen that can be activated to the enzyme pepsin that breaks down protein. So the primary functions of gastric chief cells is the synthesis and release of proenzyme pepsinogen, which subsequently in an acid environment is converted to the acid protease pepsin. And the parietal cells are responsible for releasing the hydrochloric acid. The parietal cells are located in the middle part of the glands of the fundus body region of our stomach. They secrete gastric acid like the hydrochloric acid and secrete the intrinsic factor, which is a vitamin B12 binding protein. And more acid is released with parasympathetic stimulation of the vagal nerve that will secrete acetylcholine. So acetylcholine works with hormones to encourage the stomach and pancreas to make more digestive juices. But its main function involves the movement of the digestive organs. So once released by the intrinsic nerve, acetylcholine causes the muscle layer of the digestive organs to contract with more force and increase the push of food, juice, juice through the GI tract. So it also causes the stomach and pancreas to produce more digestive juice. And the vagus nerves help manage the complex processes in our digestive tract, include the signaling in the muscles of our stomach to contract and push food into the small intestine. A damaged vagus nerve can't send signals normally to our stomach muscles. Next slide, please. So there are specialized cells called enterochromaffin-like cells that secrete gastric histamine. So the ECL cells synthesize and secrete histamine. So these cells are stimulated by the hormones gastrin, G cells. So these are stimulated by vagal stimulation through the neurotransmitter gastrin releasing peptide. So this causes the G cells to secrete gastrin, which in turn it stimulates the ECL cells to release histamine. And the histamine that is secreted will diffuse and react with histamine 2 receptors on the parietal cells, causing the parietal cells to release hydrochloric acid into the lumen of the stomach. So histamine plays an essential role in the regulation of the acid secretion by oxyntic cells in the stomach. The secreted histamine then acts through the H2 receptors on the oxyntic cells to cause the release of acid. So histamine thus transmits the actions of acetylcholine and gastrin. Next slide, please. So peptic ulcers can develop when there is a decrease in the protective mucosa layer or an increase in acid production. So peptic ulcers occur when acid in the digestive tract eats away at the inner surface of our stomach or small intestine. The acid can create a painful open sore that may bleed. And our digestive tract is coated with a mucous layer that normally protects against acid. The pancreatic enzymes, like the chymotrypsin and trypsin, is to break down proteins to smaller acids. The other lipases to break down fat, and amylases is to break down sugars. Next slide, please. Okay, so if fat is present in the bolus, the gallbladder contracts and releases bile into the small intestine. So lipids are not water soluble, which means that the water cannot absorb them or break them down. Most of the body's enzymes are water based, so the body has to use special enzymes to break down fat throughout the digestive tract. Lipid digestion begins in the stomach with the aid of lingual lipase and gastric lipase. However, the bulk of lipid digestion occurs in the small intestine due to pancreatic lipase. So, when chyme enters the duodenum, the hormonal responses trigger the release of bile, which is produced in the liver and stored in the gallbladder. So bile aids in the digestion of lipids, primarily the triglycerides. So through emulsification. So what is emulsification? Emulsification, this is a process in which large lipid globules are broken down into several small lipid globules. And some people are prone to developing gallstones in the gallbladder when the concentrated bile crystallizes. Gallstones also may form if the gallbladder does not empty completely or often enough. And certain people are more likely to have gallstones than others because of the risk factors for gallstone, including obesity and certain kinds of dieting. Next slide, please. Okay, so after secretion, now let's move on to digestion. Digestion is the process of breaking food into usable, absorbable nutrients. Digestion begins in the mouth with the enzymes in the saliva, starting the process of digestion process with muscular churning, breaking down some foodstuffs while mixing them thoroughly with hydrochloric acid and enzymes. The beginning of the small intestine introduces bile to the food bolus, which is now called chyme. So food digestion. So this is the breakdown of large food particles into smaller absorbable nutrients needed for energy production, growth, and cellular repair. So it begins with ingestion and ends with defecation. So digestion takes place in the gastrointestinal tract in the two principal forms. So we have the mechanical and the chemical digestion. So chemical digestion, so this is the physical degradation of large food particles into the smaller pieces that the digestive enzymes can access through the chemical digestion. So the chemical digestion, on the other hand, this is the enzymatic cleavage of proteins, carbohydrates, and fats into tiny amino acids, sugars, and fatty acids. So once food enters the mouth, it mixes with saliva and gets chewed through the process of mastication. So saliva, as we all know that this is rich in mucose and salivary enzymes and together with the effects of mastication. So it creates a mass called a food bolus. So the food bolus then travels down the esophagus via wave-like muscular contraction, which is called peristalsis. So before it reaches the stomach. Then, down to the stomach plays a critical role in the early stages of food digestion. So aside from squeezing and churning the food bolus, it also secretes a mixture of compounds, collectively known as the gastric juices. The gastric juice comprises of water, mucus, hydrochloric acid, pepsin, and intrinsic factors. Of these five components, we have pepsin. This is the principal enzyme involved in protein digestion. It breaks down proteins into smaller peptides and amino acids that can be easily absorbed in the small intestine. The specific cells within the gastric lining, known as the chief cells that we mentioned earlier in the secretion, it releases pepsin in an inactive form or zymogen form called pepsinogen. By doing so, The stomach prevents the autodigestion of protective proteins in the lining of the GI tract. So since the chief cells release pepsin as the zymogen activation by an acidic environment, so this is really necessary. So hydrochloric acid on the other component of the gastric juice plays also a crucial role in creating the pH required for pepsin activity. And the parietal cells produce the HCl by secreting hydrogen and chloride ions. So when the pepsinogen and the hydrochloric acid exist together in the gastric juice, pepsin takes active form. So through the action of pepsin and the squeezing properties of the stomach, the food bolus enters the intestine as a liquidly mixture of partially digested food particles. Now that is called the chyme. Next slide, please. So we have next the absorption. Absorption is the active process of removing water, nutrients, and other elements from the GI tract and delivering them to the bloodstream for use by the body. And the liver filters, clears, and further processes most of what is absorbed before it is delivered to the body. And the small intestine, the mucosa layer, as we mentioned earlier, that it is for absorption and for the secretion. This is specially designed to facilitate this absorption with long villi on the epithelial layer, providing a vast surface area for absorption. And the large intestine absorbs approximately 350 ml per day, mostly the sodium and water. So absorption. So when digestion is finished, it results in many simple nutrient molecules that must go through the process of absorption from the GI tract by blood or lymph so that they can be used by cells throughout the body. And the few substances are absorbed in the stomach and large intestine. For example, water is absorbed in both of these organs, and some minerals and vitamins are also absorbed in the large intestine. However, a large percentage of nutrient molecules are absorbed in the small intestine. The absorption of the majority of these molecules takes place in the second part of the small intestine, and this is called the jejunum. So, however, there are a few exceptions. For example, iron is absorbed in the duodenum, and vitamin B12 is absorbed in the last part of the small intestine, which is called the ileum. So, after being absorbed in the small intestine, nutrients molecules are transported to the other parts of the body for storage or further chemical modification. For example, amino acids are transported to the liver to be used for protein synthesis. And the epithelial tissue lining in our small intestine is specialized for absorption. So the thin surface layer of epithelial cells of the villi transports nutrients from the lumen of the small intestine into these capillaries and lacteals. So blood in the capillaries absorb most of the molecules, including simple sugars, amino acids, glycerol, salts, and water-soluble vitamins like vitamin C and the many B vitamins. And in the lymph in the lacteals, this absorbs fatty acids and fat-soluble vitamins. So which are the fat-soluble vitamins are the vitamins A, D, E, and K. Next slide, please. So next is we have the motility. The GI tract depends on an inherent motility to keep things moving through the system. The basic movement seen in the esophagus is peristalsis, a constant wave of contractions that moves from the top to the bottom of the esophagus. And the small intestine uses a process of segmentation with an occasional peristaltic wave to clear the segment. So segmentation, it involves the contractions of one segment of the small intestine while the next segment is relaxed. And the contracted segment then relaxes and then the relaxed segment contracts. So in motility, there are two fundamental patterns that are conducted by the digestive tube is we have the propulsion and the mixing. The propulsion is the food stuff must be propelled along the length of the digestive tube in order to be subjected to the sequential series of processing involved in this assembly and the absorption. And the principal type of propulsive motility seen particularly in the esophagus and small intestine is peristalsis. So this is a ring of muscle contractions appears on the oral side of a bolus of ingesta and moves towards the anus, propelling the contents of the lumen in that direction. So as the ring moves, the muscles on the other side of the distended area relaxes, so facilitating the smooth passage of the bolus. And we have mixing. So if the ingested materials were simply propelled through the digestive tube, we would expect that we have a very poor digestion and absorption because the digestive system, the digestive enzymes would not be adequately mixed with the ingesta, and the bulk of the ingesta would not come in contact with the epithelial cells that absorb nutrients. So we have the segmentation contraction. So this is a common type of mixing mutility seen especially in the small intestine. So this is a segmental ring of contractions that chop and mix the ingesta. So alternating contractions and relaxation of the longitudinal muscles in the wall of the gut also provides effective mixing of its content. Next slide, please. Okay, so the large intestine uses a process of mass movement with an occasional peristaltic wave. So when the beginning segment of the large intestine is stimulated, it contracts and sends a massive peristaltic movement throughout the entire large intestine. And the end result of the mass movement is usually excretion of waste products. Next slide, please. Okay, so after the four major activities of GI tract, now we have the gastrointestinal reflexes. So the local gastrointestinal reflexes involve stimulation of the nerves in the GI tract and cause movement and secretion. So we have the local reflexes and the central reflexes. So the local reflexes, this is the stimulation of local nerves within the GI tract, causes increase or decrease movement within the system, maintaining homeostasis. And the central reflexes, these are the two centrally mediated reflexes, the swallowing and the vomiting, which are important to the functioning of the GI tract. Next slide, please. Okay, so first we have the gastroenteric reflex, stimulation of the stomach by stretching, the presence of food, or cephalic stimulation. So the cephalic stimulation, this is the body's response to smelling, seeing, the tasting, or thinking about food, causes an increase in activity in the small intestine. It is thought that this prepares the small intestine for the coming chyme. So the gastroenteric reflex stimulates by stretching, the presence of food, or cephalic stimulation. And this increases small intestine activity, and this prepares for incoming chyme. While the gastrocolic reflex, this is the stimulation of the stomach, also causes the increased activity in the colon. Again, preparing it to empty any contents provides space for the new chyme. So for the gastrocolic reflex, this is the physiological reflex that controls the motility or the peristalsis of the gastrointestinal tract. So it involves an increase in motility of the colon in response to stretch in the stomach and the byproducts of digestion in the small intestine. And thus, this reflex is responsible for the urge to defecate following a meal. So the small intestine also shows a similar motility response. The gastrocolic reflex also helps make room for food in the stomach. And the duodenal colic reflex, the presence of food or stretching in the duodenum stimulates colon activity and mass movement. And again, to empty the colon for the new chyme. So this is the third type of gastrointestinal reflex. It works with the gastrocolic reflex to stimulate the urge to defecate. And this urge is stimulated by the opening of the ileocecal valve and the movement of the digestive contents from the ileum of the small intestine into the colon for compaction. Next slide, please. Okay, for the other local GI reflexes includes, we have the ileogastric reflex, the intestinal reflex, and the peritoneointestinal reflex. So first, we have the ileogastric reflex. This is the introduction of chyme or stretch to the large intestine, which slows the stomach activity and thus the introduction of chyme into the small and large intestine, allowing time for absorption. So the ileogastric reflex, so when ileum becomes distended, the ileogastric reflex, it inhibits gastric motility, and thus preventing more chyme entering the intestine ileum. So this is explained why patients who are constipated have no appetite. And for the intestinal reflex, this is the excessive irritation to one section of the small intestine causes a cessation of activity above that section to prevent further irritation and an increase in the activity below that section, which leads to a flushing of the irritant. So the intestinal reflex, this is the excessive irritation in one area of our small intestine. This stops activity above that section, preventing further irritation, and increases activity below that section to flush irritant causing water diarrhea. So this is typically seen in traveler's diarrhea. Next is the peritoneointestinal reflex. This is the irritation of the peritoneum as a result of inflammation or injury leads to cessation of GI activity, so preventing continued movement of the GI tract and thus further irritation of the peritoneum. So the peritoneum irritation is due to inflammation or injury, and this stops the GI activity to prevent GI tract movement to stop further irritation. Next slide, please. Next is we have the renointestinal reflex. This is an irritation or swelling of the renal capsule causes a cessation of the movement in the GI tract. Again, this preventing further irritation to the capsule. So renointestinal reflex, this is irritation or swelling of the renal capsule. This stops the GI tract movement to prevent further renal capsule irritation. And we have the vasocointestinal reflex. This is an irritation or overstretching of the bladder that can cause a reflexization of movement in the GI tract. Again, preventing further irritation to the bladder from GI movement. So this is the irritation or overstretching of bladder. This stops the GI tract movement to prevent further irritation to the bladder from GI tract movement, causes constipation, and seen typically in cystitis or the overstretched bladder. Next is for the last local reflexes is we have ibalik sa we have the somatointestinal reflex. So this is the taut stretching of the skin and muscles over the abdomen, which irritates the nerve flexus and causes a slowing or cessation of GI activity, preventing further irritation. So this is the taut stretching of skin mucus over the abdomen that irritates the nerve flexus. And this is also slow down the GI tract activity, preventing further irritation, but causes constipation seen with constraining clothes. Next slide, please. Okay, so after the local reflexes, we have the central reflexes. Then the first one is the swallowing. The swallowing reflex is stimulated whenever a food bolus stimulates pressure receptors in the back of the throat and pharynx. A centrally mediated reflex important in delivering food to the GI tract for processing that is controlled by the medulla. It also involves a complex series of time reflexes. So this is how it works. Swallowing, also called deglutition. This is the act of passing food from the mouth by way of the pharynx or throat and esophagus to the stomach. There are three stages involved in swallowing food. So the first begins in the mouth. Okay, so there, food is mixed with saliva for lubrication and placed on the back of the tongue. The mouth closes and the soft portion of the roof of the mouth or the soft palate rises so that the passageway between the nasal and the oral cavities is closed off. Then, after that, the tongue rolls backward, propelling the food into the oral pharynx, a chamber behind the mouth that functions to transport food and air. So once the food enters the pharynx, we have the second stage of swallowing. So it begins na. So respiration is temporarily inhibited as the larynx or the voice box rises to close the glottis. So the glottis is the opening to the air passage. The pressure within the mouth and pharynx pushes the food toward the esophagus. At the beginning of the esophagus, there is a muscular constrictor, the upper esophageal sphincter, which relaxes and opens food approaches. And the food passes from the pharynx into the esophagus is the upper esophageal sphincter, then immediately closes. So this is preventing the flow of food back into the mouth. So once the food is in the esophagus, the final phase of swallowing begins. The larynx lowers and the glottis opens and the breathing resumes. So from the time food leaves the mouth until it passes the upper sphincter, not only about 1 second of time elapses, during which all of these body mechanisms spontaneously occur. So after passing the upper sphincter movement in the esophagus, it carries food to the stomach. So the rhythmic muscular contractions or the peristaltic waves and pressure within the esophagus push the food downward. So the folds in the esophageal wall stretch out as materials pass by them and again contract once they have passed. And the lower end of the esophagus, we have the lower esophageal sphincter. It relaxes and the food enters the stomach. And the sphincter then closes again to prevent reflux of gastric juices and food materials. So swallowing, this is basically an involuntary reflex. So one cannot swallow unless there is saliva or some substances to be swallowed. Initially, the food is voluntarily moved to the rear of the oral cavity. But once the food reaches the back of the mouth, the reflex to swallow takes over and cannot be retracted. Next slide, please. So for the second one is the vomiting. The vomiting reflex is another basic reflex that is centrally mediated and important in protecting the system from unwanted irritants. So vomiting is controlled by chemoreceptor trigger zone in the medulla or by the emetic zone in immature or injured brains. So the CTZ is stimulated by several different processes and initiates a complex series of responses that first prepares the GI system for vomiting and then cause a strong backward peristalsis to rid the stomach of its content. So, vomiting is also called emesis. This is the forcible ejection of stomach contents from the mouth. So, vomiting is believed to be controlled by two distinct brain centers. We have the vomiting center and the chemoreceptor trigger zone. So, this is both located in the medulla oblongata. So, the vomiting center initiates and controls the act of emesis, which involves a series of contractions of the smooth muscle lining in the digestive tract. So these contractions begin at the small intestine and move successfully through the stomach and the esophagus until the stomach contents are forced out the mouth. So the vomiting centers responds directly to the stimuli from various parts of the body that may be stress or disease. And the chemoreceptor trigger zone, by contrast, is stimulated by many toxins and drugs. Activation of this brain region stimulates the vomiting center, so which initiates the emesis in an effort to rid the body of the toxin. And in severe cases, vomiting may result in dehydration, malnutrition, or rupturing of the esophageal wall. So treatment is directed toward the cause of the vomiting. So it is important to drink plenty of clear fluids so that further dehydration does not occur. Next slide, please. Okay, so the CTZ is stimulated in several ways. We have the tactile stimulation of the back of the throat, a free reflex to get rid of something that is too big or too irritating to be swallowed. And we have the excessive stomach distension, increasing the intracranial pressure by direct stimulation. We have the stimulation of the vestibular receptors in the inner ear, stimulation of the stretch receptors in the uterus and bladders, intense pain fiber stimulation, and the direct stimulation for various chemicals, certain drugs, and that of the cellular death. So we have the results of the vomiting, so highly coordinated series of events that could be described as the following series. So once the CTZ is stimulated, it increases salivation, increase the production of mucus in the upper GI tract, and decrease the acid production. And the sympathetic stimulation, once stimulated, it increases sweating, increase heart rate, deeper respiration, and nausea. So this is how it works. A deep breath is taken. So the glottis is closed and the larynx is raised to open the upper esophageal sphincter. And also the soft palate is elevated to close off the posterior nares. And the diaphragm is contracted sharply downward to create a negative pressure in the thorax, which facilitates opening of the esophagus and distal esophageal sphincter. And simultaneously with downward movement of the diaphragm, the muscles of the abdominal walls are vigorously contracted, squeezing the stomach and thus elevating the intragastric pressure. With the pylorus closed and the esophagus relatively open, the route of exit is clear. So we have the control of vomation. So there are four major sources. We have the chemoreceptor trigger zone, which is the bilateral set of centers in the brainstem lying under the floor of the fourth ventricle. So this is the electrical stimulation of this center does not induce vomiting, but application of emetic drugs does. So if and only if the vomation centers are intact. The chemoreceptor trigger zone functions as emetic chemoreceptors of the vomation centers. So chemical abnormalities in the body like emetic drugs or uremia, hypoxia, and diabetic ketoacidosis. So, when this is sensed by the centers, the centers send excitatory signs to the vomation center. So, many of the antiemetic drugs act at the level of the chemoreceptor trigger zone. And we have the second major sources. We have the visceral afferents from the gastrointestinal tract, which is the vagus or sympathetic nerve. So these signals inform the brain of such condition and the gastrointestinal distension. So this is a very potent stimulus for vomation and mucosal irritation. And we have the visceral afferents from outside of the gastrointestinal tract. So this includes signals from the bile ducts, the peritoneum, the heart, and a variety of other organs. So this inputs to the vomation center. This is helps explain how, for example, a stone in the common bile duct can result in vomiting. And lastly, the afferents from extramedullary centers in the brain. It is clear that certain psychic stimuli like odors or fear, vestibular disturbances like motion sickness, and cerebral trauma can result in vomation. Next slide, please. Okay, so that's all for the introduction of the gastrointestinal system. So hope you have learned from it. Thank you.
Okay, so good morning, everyone. Good morning, Doc. Now we're going to move on to the drugs affecting gastrointestinal secretions. So first, we have to know what are these drugs. So we have here drugs used to treat gastroesophageal reflux disease and ulcer disease. So unsa man ni sila? We have here histamine 2 antagonist. So we have their cimetidine, famotidine, nizatidine, ranitidine. By the way, ato ni silang ila-ilahon later on. And we have also here antacids, our aluminum salts, calcium salts, magnesium salts, sodium bicarbonate. Okay, we have also proton pump inhibitors, which are those drugs ending in prazole, and a GI protectant, which is a sucralfate. And then your digestive enzyme, you have to these drugs used to treat digestive enzyme dysfunction, which are the pancreolipase and the saliva substitute. Okay, first we have gastrointestinal disorders are among the most common complaints seen in clinical practice. So, underlying causes of these disorders can range from dietary excess, stress, hiatal hernia, esophageal reflux, and adverse drugs effects to the more serious peptic ulcer disease. So we have first to tackle what is peptic ulcers. So very common, maybe naamuani or familiar rin ni siya. So peptic ulcers are erosions in the lining of the stomach and adjacent areas of the GI tract. So patient may present with a predictable description of gnawing, burning pain often occurring a few hours after meals. So, a chronic peptic ulcer is believed were caused by excessive acid production in your stomach. So, what will be the treatment of this? Of course, we have to aim at neutralizing acid or blocking the parasympathetic system to decrease normal GI activity and secretion. So, remember that parasympathetic system can increase GI activity. So we have to block parasympathetic system. Next is the chronic peptic ulcer. So since acid production was often normal in ulcer patients, ulcers were caused by a defect in mucous lining. What is the mucous lining? It is a layer that protects your stomach, that coats the inner lumen of the stomach to protect it from the digestive enzymes. So currently, it is believed that chronic ulcers may be the result of impaired mucous lining and infection by your one of the bacteria, Helicobacter pylori. So acute ulcers or your stress ulcers are often seen in situations that involve acute physiological stress such as your trauma, burns or prolonged illness. So the activity of the sympathetic nervous system during stress decreases the blood flow to the GI tract, meaning or leading to less blood flow to the inner layer of the GI tract and weakening of the mucosa layer of the stomach nga munang makalid na siya erosion sa imuhang stomach because of the acid. So what will be the treatment? Of course, many of these drugs available for treating various peptic ulcers act to alter the acid producing activities of the stomach to decrease the erosive action. So how about digestive enzyme dysfunction? So patients with stroke, salivary gland disorders, or extreme surgery of the head and neck may not be able to produce saliva. Okay, we have to remember or discuss na ni kanina that saliva is important in the beginning of the digestion of your sugars and proteins and is essential in initiating the swallowing reflex. So artificial saliva may be necessary for those patients kay dili man enough ang na-produce nila nga saliva to digest the foods. And then patients with common bile duct problems, pancreatic disease or cystic fibrosis may not be able to produce or secrete pancreatic enzymes. Nasa like defects silang pancreatic area. So these enzymes may need to be administered to allow normal digestion and absorption of nutrients. So what are those drugs used to treat gastroesophageal reflux disease and ulcer disease? So we have first, okay, increase GI acid work to decrease GI secretory activity, block the action of your GI secretions, and four, protective coverings on the GI lining to prevent erosion from GI secretion. So first, we have histamine 2 antagonist. You all know or na-discuss na kanina na ang histamine 2 will cause stimulate the parietal cell to release the hydrochloric acid to your stomach. So we have to block this. We have to block the release of hydrochloric acid in the response to gastrin. We also know na imong gastrin mo stimulate na siya because like naka-sense ka og food, nakahunaw na ka og food. So that will stimulate the enzyme gastrin. Next is the antacids, which interact with acids at the chemical level to neutralize them. So it will neutralize the acids in your stomach. So since there is no perfect antacid, so ato man gi-alter ang normal environment sa atong stomach, so na siya mga adverse effects. We will know later on. Next is the proton pump inhibitors, which suppresses the secretion of your hydrochloric acid into the lumen of the stomach. And then your GI protectants, so which coat any injured area in the stomach to prevent further injury from acid. And your prostaglandins, which inhibit the secretion of gastrin and increase the secretion of your mucous lining of the stomach, providing a buffer. So we have here illustration kung asa nag-work atong mga different drugs. Okay, so okay, drug therapy across the lifespan. We have it is very important kay common man gud ang mga GI drugs kay muna siya ang dali natong like most of them are available in OTC preparations. So famotidine is the only H2 antagonist approved for use in children. Okay, and proton pump inhibitors no not specifically indicated for use in children, but you can use lansoprazole as established for NASH pediatric doses. A proton pump inhibitor is most appropriate. We have also here antacids may be used in children who complain of upset stomach and who are receiving therapy known to increase acid production. Special caution should be used with any of these agents to prevent electrolyte disturbances or any interference with nutrition which could be possibly detrimental to children. So adult, we have also to caution not to overuse any of these agents, especially most of these agents as OTC drugs. So basin ga mugna-mugna ra ang ubang patients or some adults nga sa doses sa ilang tambal. So and to check whether healthcare provider if GI discomfort continues after repeated use of any drug. So patient should be monitored for any electrolyte disturbances or interference with absorption or action of the other drugs. So if antacids are used, they should be spaced 1 to 2 hours before or after the use of other drugs. So studies were published that link prolonged use of these agents with increased incidence of colitis, inflammation of your colon, and other GI infections, electrolyte imbalance, bone loss, hypertension, and other systemic issues. So patients should be cautioned to limit the use of these drugs and to seek medical help for persistent symptoms. And also for adult, the safety of this drug during pregnancy and like it has not been established. So just like any other drug, dili siya po siya safe. You should be cautious if you have to ikon sa like pregnant or lactation women. So they should be used with caution during pregnancy or lactation, especially your misoprostol. We have as one of your available preparation of your prostaglandins. Now, okay, we have here. Misoprostol is an abortive patient and should never be used. Diba? Should never be used during pregnancy. So women of childbearing age who use misoprostol should be advised to use barrier type contraceptives. Use of the other agents should be reserved for the situation in which the benefit to mother outweighs the potential risk to the fetus. Sumunod siya na ang if ever we will we should be think that the benefit should outweigh the potential risk. The drugs may enter breast milk and also may alter electrolyte levels or gastric secretions in the neonate. It is advised that caution be used if one of these drugs is prescribed during lactation. And older adults should be those frequently are prescribed one or more of these drugs. So older adults are more likely to develop adverse effects associated with sedation, confusion, dizziness, urinary retention, and CV effects. So okay, and safety measures are needed if these effects occur interfere with a patient's mobility and balance. So because of changes that occur within the GI tract with age, absorption of nutrients can be affected with any of this drug is used. So the use of your proton pump inhibitors or H2 blockers in older adults has been associated with decreased absorption of vitamin B12. Why? We will talk about it later on, and the development of your pernicious anemia. Okay, and it can cause likely to have renal or hepatic impairment or related to underlying medical conditions. So they should be advised to check with their healthcare provider before beginning any OTC drug regimen. And proton pump inhibitors may be best choice for treating your GERD or in older patients because of your fewer adverse effects of these and a better therapeutic response with other drugs. Okay, we will talk about the histamine 2 antagonist. So it will block the release of hydrochloric acid in response to gastrin rather. So we have here cimetidine, famotidine, nizatidine, and ranitidine. So all those drugs na like gaan lang siya og din. So, what is the therapeutic actions of this H2 antagonist? It is a selectively block H2 receptors located on your parietal cells. So, blocking this receptor prevents the release of gastrin, which is a hormone that the local causes local release of histamine due to the stimulation of your histamine receptors. Ultimately, blocking that it will really block your production of your hydrochloric acid. So, this action also decreases your pepsin production by the chief cells, and H2 receptor sites are also found in the heart, and high levels of these drugs can cause cardiac arrhythmias. Okay. Then we have also the therapeutic actions and indications. So, a short-term treatment of active dural ulcer or benign gastric ulcer. We have treatment of pathological hypersecretory conditions such as your Zollinger-Ellison syndrome, which is Zollinger-Ellison syndrome is like the overproduction of your hydrochloric acid, and it can be a prophylaxis of stress-induced ulcers and acute upper GI bleeding in critical patients. And then it can be a treatment of erosive or gastroesophageal reflux. Okay, it will be decreasing the acid being being regurgitated into the esophagus will promote healing and decrease the pain. So relief of symptoms of heartburn, acid indigestion, and sour stomach. And then we have pharmacokinetics, cimetidine, ranitidine, and famotidine are available in oral and parenteral form. So nizatidine is available in oral form. Cimetidine was the first drug of this class to be developed. So ang cimetidine. So we will not talk. So here, ranitidine is a longer acting and more potent than cimetidine. It is not associated with any anti-androgenetic
Okay,
adverse
okay.
events.
Dali lang ha. Dali
Yes,
lang.
ma'am.
One important thing with regard to cimetidine, you did not elaborate it. Imo nang gisulat diha, but you did
Yes,
not
yes.
mention
Sorry,
it.
sorry.
With regards to the side effect of your cimetidine, cimetidine, by the way, is the first of its first drug in its class, the H2 blocker, cimetidine. This is the oldest H2 blocker. Cimetidine has been found to be very effective and safe children. That's why most of the H2 blockers used for children are cimetidine. Of course, there are newer studies now that enable us to use the other H2 blockers also. But the one that is most commonly used and the safety profile is good, expoundly studied, is your cimetidine. Now, side effect of which, because it is the longest running drug sa market, the oldest nga AIDS blocker, makita po nimo ang mga side effect niya na kay as time goes, makita nimo mo din side effect niya. So which means gynecomastia and galactorrhea, of course, is one of the side effects of your cimetidine. That's why kung mga laki din nga ganahan nga magpadako og tutoy, you can use cimetidine. But you will also have achlorrhea in the end, decrease in your hydrochloric acid. Kay lagi, it is an H2 blocker. With prolonged use, it is not good. It is only good for the treatment. So that is with your H2 blocker nga cimetidine. On the rest, bago-bago pa man, wa pa ta kay balon sa ilang mga side effects, long-term side effects in the future. Wa pa man ta kay balon. Okay? So continue. Before you continue, let me just refresh you on the anatomy and physiology before you can go further, ha? Ato tong i-review inyong anatomy and physiology because introduction is one of the most important aspects in the study of drugs affecting the system. Now, it has been mentioned na from ang inyong gastrointestinal system is an open system. Open kay gikan siya sa mouth open man pero sa lubot open po siya. Now, is the gastrointestinal tract, the tract mismo does not include the liver and the pancreas because the food does not pass through the liver and the pancreas. So it does not include ang tract ninyo. But the gastrointestinal system or the digestive system includes your um, pancreas and your liver. Your pancreas is included because it secretes your digestive juices, your mga pancreolipase, may nga nana. Yung mga lipase from the pancreatic juice, which you know would lyse your fats na daghan na siya. Also, there are juices, there are amylases in your pancreas, pancreatic amylase, which digest your starch or your carbohydrates. Your amylase is also found in your saliva. We have a salivary amylase. It also digests starch. It digests carbohydrates into simple forms before it can be absorbed because your complex carbohydrates cannot be absorbed. Again, your complex carbohydrates cannot be absorbed by your GI tract. It has to be converted to the simple form. Okay, your monosaccharides. Okay, so polysaccharides again cannot be absorbed. It is the monosaccharides that can be absorbed, your simple sugars. So it has to be converted there. We have mentioned already, I guess, ato ang hormones yata to, or katong the treatment of diabetes regarding the use of your inhibitors sa imuhang digestion or conversion of your complex carbohydrates to simple sugar, your acarbose. Okay, now, uh, Let's go back to your digestive system, the introduction, again from the mouth, by the process of mastication. Mastication. Okay. Ang taste is gustation. Ang chewing is mastication. So it goes through by the aid of your teeth, the teeth aids in digestion. So it has different functions in yung incisors, in yung uh, canines, your premolars, and the molars. It has different functions. But it's not our concern karon. Ang concern na to ano functions niya will be in 305 na sa inyong third year, second sem, medical surgical nursing. Now, again, this helps in in your mastication, yung teeth, your tongue also aids to move, to propel the food from the front to the back. Now, by the way, the process of deglutition or your swallowing or deglutition. The process is both active and passive, and reflex. I mean, active kay you propel the food from the anterior area of the mouth to the posterior area by way of your tongue. But once it reaches the pharynx, it reaches a point of no return unless you gag it out. Okay? Now, by the process of gag reflex, pwede na siyang mapagawas ninyo if makaya. If not, then na ma-choke mo o mag-gag mo. Now, by the process of by reflex action, once it touches the pharynx, it will now be the reflex that moves this food down into your esophagus. Again, it is a reflex action. Now, gravity aids. I am not saying gravity does not help. Gravity helps also in the movement of the food. However, when you're lying down, let's not go over the you're lying, you can still open the book from the box to the autography, okay? So, bisa kaya kaya mo lagi mo na po sa pag ang ita sa it level to go to your lahat at level sa iba rin is one important sa inyo na sa live that you are with the for food I don't know chemical that you take sa food. So, you will know really sila unless like chemical tao para ayo for 5 minutes again na Increase the pressure sa iyong lower esophageal sphincter. Na. So going further, if ever na may GERD, you can use H2 blockers or mga proton pump inhibitors. Now, we'll now go to your acid production. Now, your stomach is coated with, the lumen of your stomach is highly acidic. It is really very, 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 very acidic ang iyong lumen sa stomach. But why is it that your stomach dili malinis sa inyong acid? Because acid will digest the mucosa, the lining of your stomach. It is because the mucosa of the stomach is rich with mucus. It is mucus producing. The mucus renders the lining of the stomach basic, which means na counteract ang effect sa acidic nga lumen sa basic nga coat sa stomach. However, there are cases that will destroy the mucosa of the stomach, like chronic use of alcohol, chemicals, drugs that will decrease the mucosal secretion of the stomach lining. Now, with the decrease in mucosal secretion, this will trigger now the effect of um, the injury sa stomach wall brought about by the acid. Kaya lagi, naminusa naman ang inyong mga mucus sa stomach wall. So once the highly acidic lumen, the acid in the lumen will touch the area nga na decrease na mucus production, that will cause now the injury. That's why you will have stomach ulcer. Now, stress can also increase stomach ulceration, by the way. It increases ulceration and stress. So, ayaw mo pa stress, balag mahagbong sa exam, ha? Ayaw na yun. You know that there are a lot of effects sa imuhang stress aside from imuhang stomach ulcer, also cardiac problems. Okay, they are brought about by stress, as I have stated earlier sa atong topic on cardiovascular drugs. Now, going further, ang inyong parietal cell of the stomach will produce two types of chemicals. Your hydrochloric acid is responsible for the acidity of the stomach. Now, your hydrochloric acid is really very important for digestion. It aids in digestion. However, it will also cause ulceration of the stomach if the stomach lining is not that protected with mucus. I already told you examples of how the stomach lining will decrease its protection, its mucosal protection. Now, your there are drugs that will increase the lower esophageal sphincter pressure. There are drugs that can treat the GERD. Now, the parietal cells again will secrete your hydrochloric acid, responsible for digestion, and also secrete your intrinsic factor, responsible for the absorption of vitamin B12. So, if ever you cut the sources of your parietal cells, you will have decreased acid production and you will have decrease in intrinsic factor production. Your intrinsic factor again helps in absorption of vitamin B12. Now, if you don't have intrinsic factor, you have deficiency of vitamin B12 absorption, causing now your pernicious anemia. The pernicious anemia is a type of megaloblastic anemia. Okay, that will is still a type of anemia. Also, decrease ang imuhang RBC production o ang imuhang hemoglobin ma-decrease. Okay, that is one type of anemia. Pernicious anemia is caused by deficiency of the intrinsic factor. If you have deficient parietal cells sa inyong stomach. Okay, now your acid also is promoted by the secretion of your hydrochloric acid is promoted by the activity of your vagus nerve. Again, the vagus nerve is the largest nerve, the longest nerve in the body. It reaches up to the stomach. So the vagus nerve is responsible for the production of acid from the parietal cell. So if you cut the vagus, there will be no production of your cut the vagus at the end na katong dito na siya sa imong parietal cell na stimulate, it will now it will now inhibit the production of your hydrochloric acid. Such that a long time ago, not so long time ago, one of the treatment of recurrent ulcers, recurrent stomach ulcer, and intractable hyperacidity is transection of the vagus nerve. We operate on patients, cut the vagus nerve supplying the stomach. But it is not the whole vagus that we cut. We call it highly selective vagotomy or HSV. When you cut the vagus directly supplying those area producing your parietal cells, are located at the parietal cell, this will decrease the production of hydrochloric acid from that area ng mga parietal cell. So that will now solve the problem of hyperacidity caused by intractability to, to drugs. So there are, you know what is intractability? Intractability means dili mo respond ang condition sa drug that is intractable. Okay? So that is one, sauna, that is surgical indication for hyperacidity that is intractable. Okay, now that is acid. By the way, with regards to your it is not our at least I think we have discussed already the treatment of your pernicious anemia in our blood. Anemia na to, I think we have discussed that. It's not our problem now. Our problem will be on the hydrochloric acid. Now, with regards to the production of hydrochloric acid, please take note that you can treat acidity in the stomach in around four levels. First is ana maguni ang step sa production of hydrochloric acid, di ba? From the proton pump, release of hydrogen from the proton pump attached to your the histamine will now be attached to your histamine 1 receptor so that it can release now your hydrochloric acid. Okay? From the HK80 phase. Okay. HK80 phase is your what you call your proton pump. Okay, it is where the hydrogen is released. Again, HK80 phase or your proton pump. That is the enzyme responsible for the production of your hydrogen, causing your acidity. By the way, again, that's the first step. The second step is you inhibit the attachment of your H to your H1 receptor. If you inhibit your H1 receptor, you do not release hydrochloric acid. Okay. The third step is once you release already the hydrochloric acid, you can neutralize it by giving your anti-acid or your antacid. So you release the hydrochloric acid, you neutralize na nimo. And if wala nimo na apte naka-affect na gyud o wala na-release na hydrochloric acid, wala na naka-affect po ng imong antacid, you may protect the wall of the stomach by giving mucosal protective agent. Okay? You coat the wall of the stomach so that the acid cannot act on the wall, injuring it. So to prevent injuring the wall, you can coat the mucosa. There are a lot of drugs that are mucosal protective agents. Again, at the very start, you can inhibit the proton pump. Then, second step, kung wani mo na update on, release na yung hydrogen yun, you can block your H2, your H2 receptor. Not H1 ha. H1 is your histamine. Nakalimot ha. Basig na H1 ako na-mention ganina. Basig nakalimot ko. It's not the H1, the H2 ha. Please check that. Please correct that. It's the H2. H2 blocker. Histamine 2 receptor. So you can block the H2 receptor, preventing the release of your hydrochloric acid. So kung wala yung ma-release ng hydrochloric acid, wala acidity, wala yung increase acidity sa lubid sa stomach. So once wala mo na-upti sa imong H2, naka-attach sa imong H2, then na-release yung hydrochloric acid. You can neutralize now. Third step, you can neutralize the acid in the lumen of the stomach by giving your antacid. There are a lot of antacid. Now, just caution lang ha, your metallic antacid like your aluminum, metallic metal man siya, aluminum is metal. Aluminum hydroxide will promote constipation, whereas your magnesium will promote what you call this, diarrhea. Okay, so to neutralize both, you do not apply each individually. You mix aluminum and your magnesium. Okay? So that mag-away ang ilang constipation, constipative effect o diarrheic effect. So neutral na, walay constipation, walay diarrhea. That's why we have your maalox, your aluminum magnesium hydroxide, or magnesium aluminum hydroxide. That is maalox. Combination of your aluminum and your magnesium. Okay? Now, that is antacid. We have a lot of H2 blockers, mentioned already, mga it ends in pidin. Your proton pump inhibitors, or your HK-ATPase inhibitors ends in prazol. Ah, antacid, of course, you know what antacids are. And we have mucosal protective agents. We have a lot. It has been mentioned before I interrupted this report. It has been mentioned yung mucosal protective agents includes your prostaglandin preparations, your mga misoprostol, which is an abortifacient, which we discussed sa inyong mga abortifacient agents. Okay, there are a lot of mucosal protective agents. There are metallic protective agents like your bismuth. Now, one disadvantage of bismuth is it may mask the bleeding, the bleeding sa inyong GI tract. Guys, because ang imuhang stool will be black or uh, black colored stool or black tarry stool with your bismuth. The same is true with iron. When you take iron, ito man yung stool. You might misinterpret it as bleeding or hematemesis or na what you can hematochezia, hematemesis, etc. Dili na hematemesis ha kay kanang hematemesis is kanang mo vomit. Hemoptysis ang mo vomit. Hematemesis, hematochezia is sa inyo nga GI. Okay. Imo hemoptysis, you cough out or you cough out blood. That is hemoptysis. Hematemesis, hematochezia is a GI ninyo. Okay, differentiate hematochezia from hematemesis. Differentiate. One is kanang fresh blood, one is kanang old blood or kanang oxidized blood nga itom na. Okay? So differentiate one from the other. What's pa lain? So, mucosal protective agent. Now, why is it nga dili your liver is included in the digestive tract or the GI tract, not tract system. It is included in the digestive system because it produces bile. Bile is responsible for digestion of fat. Okay. Now, uh, regards the formation of your gallstone also, gallstone is, as has been mentioned earlier, is by ma-concentrated na gani na ang inyong bile sulod sa inyong gallbladder that will start now the formation of stone by crystallization. Again, supersaturation of your bile inside your gallbladder will initiate crystallization and thus stone formation. So it starts with supersaturation. Why will there be supersaturation? Because your gallbladder will absorb the fluid, the water from the bile that is stored in the gallbladder. Because the gallbladder is only for the storage of your bile. So once the bile is stored in the gallbladder, the gallbladder will also absorb water, causing now saturation of the bile. Now, if there will be supersaturation of bile, that will now cause the crystallization, thus creating a nidus for stone formation. Okay. Now, there are drugs that will decrease the accumulation of your bile acid. Okay. There are bile acid binding resids. Okay. Now, there are also drugs that will decrease the in, uh, accumulation of or the adding of the growth of your stones sa inyong gallbladder. Okay, like your mga orthodeoxycholic acid that will decrease the chances of further progression of stone formation. Na, dili man niya ipa-tapot-tapot ng imuhang mga bile acid sa inyong needles. So, it may help to decrease the stone formation. May help, but it is not 100%. Okay, so your orthodeoxycholic acid. So once your gallstone is already symptomatic, na pain, you better have it removed na yung gallbladder. Okay, kay base nun niya kung mo-block na sa inyong common bile duct. We'll be discussing the abnormalities in your 305 third year. Now, going further, once uh, nanaog na ang inyong food, no, magigaling sa inyong stomach, it will go down to your small intestine. Will the actual absorption of nutrients happen? Actual digestion happens in your small intestine. Do not forget that. Now, once it reaches the small intestine, it goes past to the large intestine where maximum absorption of water happens. Again, maximum absorption of water happens in the large intestine. Para nga, ang mugawas nga tae, dili tubigon, ang mugawas nga tae, tibuok na siya. Form stool. If you absorb most of the water sa inyong large intestine. That's that. If your movement of your gastrointestinal tract will be very slow, like sa mga elderly, slow ang movement sa GI tract, it will absorb the large intestine will absorb so much water kay hinay makayog lihok magiging absorb sa water nga mag-constipate na ka. So decrease in movement will cause constipation. While the opposite happens, kung pas-pas na po kayong movement sa GI tract, it will cause diarrhea. Why? Because you will have less chance of absorbing your water sa inyong large intestine. Did you get that?
Yes, Doc.
Okay,
Yes.
so treatment of the conditions that we have, the simple conditions that we have mentioned, treatment will be mentioned by the group. Ang kato siya. Ang ako lang tagaan lang tamo og refresher sa inyong possibilities that will happen with the movement of food from the mouth to the anus. So you may now continue. Okay.
Okay, thank you so much, Doc. Alain Kaday.
Wala man. What happened? Basig off yung mic.
Ay, Miss. Kaana, Miss. Metodi na, Miss. Na slides. Okay, so, na-discuss naman ni Doc Nanan. So, let's continue na lang to next day. Miss.
Caronia. Noel V. Caronia. Mara mag-cotics ng Caronia. Sige, Colonia di ay. Sorry. No, Caronia. Sige, padayon. Ano, basig ni Kaging siya. Saba, dili siya ni Kaging.
Yes.
Iya, di nga laptop.
Yes,
Miss
Doc. Sorry, Doc.
Colonia. Ay, basig nalibang pa. Nalibang pa ka, Miss Colonia? Oy, wala na. Sige. Pangitalag laing kuan inday mo present.
Yes, sorry kay Doc. Yes, Doc. Pwede ka, Miss Angel Mandantes.
Yes, ate. Kajut lang.
Thank you.
Anong ate ka? Anong gihati ka nila, Miss Pancho?
Ay, basin, charot. Ay, mutwaniwan naman good ko, Doc.
Ala, dili biya na siya. Bad biya na imong ate ka. Abi palang gulang. Kabata ka na Miss Pancho. Na, tanawa. Pinagunit-gunit sa chin. Ganyan yung picture. O, pinahangat-hangat.
Maulaw to, Doc. Thank you, Doc. Okay.
Ninay Aquino. O, di ba? Ang iyang post. Ninay Aquino post. Sige, 500 pesos. Sige, go.
Okay, so next is manamatag cimetidine, so we'll go to nizatidine. Ang kaalang sa nizatidine is it is a drug of choice for patients with liver dysfunction nga naman because it has a no first pass effect on the metabolism and the liver. Okay. So I forgot that kanina cimetidine is also yung adverse effect is gynecomastia and galactorrhea because it is an androgen receptor antagonist. Okay, so next. Okay. So the H2 antagonist should not be used with known allergy to any drug. So just like any other drug rapod, so dili siya pwede if na siya known allergy to that drug or to the drugs of this class to prevent hypersensitivity reactions. Because caution should be used during pregnancy or lactation because of the potential adverse effect of the fetus and the nursing baby. And with hepatic or renal dysfunction, which could interfere with drug metabolism and excretion. Okay, so care should be also taken in prolonged or continual use of this drug if necessary because they may be masking serious underlying conditions na pod. Okay, so next. Okay, what are the adverse effects? So, I'll just highlight paramecia, you have GI effects, you have diarrhea or constipations. So, why is it there is a cardiac arrhythmia in H2 antagonist? Remember, you antagonize your H2 receptor will cause an increase in heart rate. So, you antagonize it, might be you may experience a bradycardia or uh, okay. Sorry, doc. Cardiac arrhythmia sa mao to. So, and gynecomastia and impotence because it is an androgen receptor antagonist. So next. Hello. Next, okay. So assessment, we have what is our nursing considerations of patients receiving histamine 2 antagonist. So we have just to read this one. So assess for possible complications of allergy. Are there any detailed description of GI problem, including your length of time of disorder and medical evaluation to evaluate appropriate use of this drug and possibility of underlying medical problems and of course, if the current status of pregnancy or lactation because of the potential adverse of this drug to the newborn or to the fetus. Okay, next. So another, you also have to perform physical examination to obtain baseline data, inspect for skin or evidence of lesions or rash, basin adverse effects such as the tambal. And then, evaluate neurological status. And then you have also, yes, next na. Access cardiopulmonary status including pulse, you have your blood pressure, your ECG, and then perform abdominal examination and then monitor the results of laboratory tests. Next. And then we have here our nursing diagnosis. And the next. Okay, you have our planning. Okay, then next we have our implementation and rationale. So you will just read this one. Well, magtuon ka. Okay, well, okay, next is coming to antagonist. Arrange for regular follow-up to evaluate the drug effects, and then offer support and encouragement of the patient, and then provide the patient for teaching about this drug, the dose, the name of this drug, and the schedules. And then we have our evaluation. Okay, next. Okay, now we will going to move on to antacid. So these are group of inorganic chemicals that neutralize the stomach acids na mention na ni Doc kanina. So we have here aluminum salts, your calcium salts, magnesium salts, and sodium bicarbonate. So next. Okay, so antacid neutralize your stomach acid directly by direct chemical reaction. So they're recommended for the symptomatic relief of upset stomach if nakay hyperacidity as well as the hyperacidity associated with peptic ulcer, gastritis, peptic esophagitis, gastric hyperacidity o mga hiatal hernia or like okay, or like the upper part of your stomach kanini bulge, yung libet sa your hiatal hernia. And then, one common among OTC example of antacid is just like Kreml S. Okay, pharmacokinetics. So we have here sodium bicarbonate is the oldest drug in this group. Is readily available in preparations. So these including baking soda powder, tablet solution. So this drug is widely distributed and absorbed orally. Okay, it is excreted in the urine and can cause serious electrolyte imbalance in people with renal impairment. Okay, next. Okay, haning calcium carbonate I mentioned na pud ni kanina nga it can cause constipation. Okay, so it can be absorbed systemically and cause calcium imbalance. When absorbed, it is metabolized in the liver and excreted in the urine and the feces. And also your magnesium salts. Your magnesium salts is a natural laxative that is from makapromote siya og diarrhea unlike opposite to your calcium. Okay, it is a very effective in buffering acid in stomach but have been known to cause diarrhea. They are sometimes used as laxatives. So they are natural laxatives. So they are available as tablets, chewable tablets, and capsules in liquid form. Although these agents are not generally absorbed systematically and are secreted in the feces, absorbed magnesium can lead to nerve damage, coma, and if absorbed, it is excreted in the urine. So, yun si Doc kanina, so that dili ta magkakuha ng mga adverse effect, we have to take, do not apply or take it individually, have to mix it. Okay, next. Then we have also our aluminum salts. Okay, it can, okay, they are bound in the feces for excretion. They have been related also to severe constipation. And then many of the acids and toxins are available in combination form to take advantage of an acid neutralizing effect and block the adverse effects. For example, a combination of, okay, yeah, salty na po ni Doc kanina, calcium and aluminum salt buffers acid and produces their constipation or diarrhea. Okay, next. So what are the contraindications? That's say para gyapon same with any other drug with the presence of allergy, or any component of drug to prevent hypersensitivity, and then any condition that can be exacerbated, like example, electrolyte or acid base imbalance, to prevent exacerbations and serious adverse effects of your electrolyte imbalance, which could be exacerbated by the electrolyte changing effects of this drug. So GI obstruction, which could cause systemic absorption of the drug and increase adverse effect. Okay, we have also renal dysfunction, which could lead to electrolyte disturbance if any absorbed antacid is not neutralized properly, and pregnancy and lactation because of the potential adverse effects. Okay, next. Okay, adverse effects also. Administering an frequently causes acid rebound in your stomach, produces more acid in response to the alkaline environment. Kaya di ba, normal man sa imuhang stomach nga acidic siya. So maybe it can cause an acid rebound. So utilizing the stomach contents to an alkaline level stimulates the gastrin production to cause an increase in acid production na hinoon and return the stomach to its normal acidic state. So in many cases, acid rebound causes an increase in symptoms which results in an increased intake of antacid. So this leads to more acid production and an ongoing cycle sa magbalik-balik na siya. So when more and more antacid is used, to the risk for systemic effects rises. Okay, next. Alkalosis with resultant metabolic changes. Okay, we have here the use of calcium salts may lead to hypercalcemia. Of course, kay intake man ka og calcium. So there will be an increased level of calcium in your body, and constipation or diarrhea may result depending on the antacid being used, depending katong either calcium carbonate ba or katong magnesium salts. Okay, next. Antacids can greatly affect the absorption of your from your GI. Most drugs are prepared in acidic environment, and alkaline environment can prevent them from being broken down for absorption, or can actually neutralize them so that they cannot be absorbed. So patients taking antacids should be advised to separate them from any other medications by 2 hours. So if the pH of the urine is affected by large dose of antacid, the levels of drugs such as quinidine may increase and the levels of salicylates may decrease. Okay, next. So, what are our nursing considerations? So, you have to assess for possible contraindications or cautions or any allergy, and then perform physical examination. Also, next, we establish baseline data. We have also inspect the abdomen. We have to also collect the bowel sounds, ensure GI motility, assess membrane status, about potential problems, and we have to monitor any laboratory test results. Include serum electrolyte levels because we have to monitor this one. Okay, next. Okay, what are our nursing diagnosis? So here are some. Okay, next. And then the planning. Okay, next. And then implementation. And then next. And then we have to evaluation now. So monitor patient response to the drug, monitor for adverse effects, evaluate the effectiveness, and monitor the effectiveness of comfort measures and compliance with our regimen. Okay, next. Okay, next up that there's a proton pump inhibitor. So what is a proton pump inhibitors? Okay. So this suppress the secretion of your hydrochloric acid in the lumen of the stomach. So kaya ending ang mga prazole, these are your proton pump inhibitors. So imo rang i-take note nga i-suppress the secretion of hydrochloric acid into the stomach. Okay, next. Therapeutic action. Okay, your gastric acid or PAP inhibitors suppress gastric acid secretion by specifically inhibiting the hydrogen potassium adenosine triphosphate katong gi-mention ni Doc kanina, an enzyme system on the secretory surface of the gastric parietal cell. So this action blocks the final step of acid production, lowering the acid levels in your stomach. Okay, that is the work of your proton pump inhibitors. Next, X. Ajo. They're recommended for short-term treatment of duodenal ulcers, GERD, corrosive esophagitis, and benign active gastric ulcer for the long-term treatment of pathological hypersecretory conditions. So, as maintenance therapy for healing of erosive esophagitis and ulcers, and in combination with amoxicillin and clarithromycin, these are antibiotics for the treatment of your Helicobacter pylori. Okay, next. So, pharmacokinetics, so esomeprazole, lansoprazole, your pantoprazole are available in delayed release of oral forms. So, this drug is are acid level and are rapidly absorbed from the GI tract. So, okay, omeprazole is faster acting and more quickly excreted than the other proton pump inhibitors. Esomeprazole is a longer acting drug, and then it is not broken down as rapidly liver as the parent drug omeprazole. So your lansoprazole has a long half-life of 2 hours and duration of the. Remember, your lansoprazole is available drug of choice of children if need nila o proton pump inhibitor. Okay, next. So, pantoprazole and rabeprazole. Okay, this dexlansoprazole is available in a delayed capsule that offers 2 releases. Okay, so you have to read that one. There are no adequate studies about whether these drugs cross placenta or enter breast milk, but you have also to be cautious, Richard. Okay, next. Okay, so contraindications and action parihara. You have to contraindicate that in the presence of known allergy to either the drug or the drug components to hypersensitivity, and of course to the pregnant and lactating women. Next, Osepsa lansoprazole, which is available siya sa children. And then the adverse effects. So these drugs are related to the effects on that enzyme pump on the parietal and other cells. So CNS effects, then your GI effects on your upper respiratory tract symptoms like cough, stuffy nose, hoarseness, and epistaxis. Next. So other less common adverse effects, so nana kay magka-rashes, magka-alopecia, and then in preclinical studies, long-term effects of proton pump inhibitors induce the development of your gastric cancer. So recent study shows an increase in bone loss and decrease in calcium levels, decrease in magnesium levels, leading to hypertension and increase in incidence of Clostridium difficile, diarrhea, and pneumonia. Why? Kay imo bang neutralize ang acid sa imong stomach. So, makatribe na hinon dito ang bacteria, like example, yung Clostridium difficile man ang magka-diarrhea. Or and then if na overgrowth sa bacteria sa imuhang in your stomach, it can go up, makasaka siya sa imong esophagus down to your up to your uh, uh, upper nasal area, and then makakause na siya og pneumonia. Okay, next. Okay, this is an illustration. Okay, consistent. So, drug to drug, there is an increased serum levels and increased toxicity of benzodiazepines, phenytoin, and warfarin. If these are combined with these drugs, patients should be monitored closely. Decreased levels of ketoconazole and thiopylene have been reported with combined with these drugs, leading to loss of effectiveness. So, sucralfate is not absorbed well in the presence of these drugs, and doses should be spaced in 30 minutes. By the way, your sucralfate is your GI protectant. Okay, next. Okay, what are our nursing considerations? So we have to assess for possible allergy gyapon, perform physical examination. Next, inspect for any skin rashes or lesions, assess neurological status, inspect and palpate the abdomen, assess respiratory status, and then the patient will receive the best therapeutic effect. The patient will have limited adverse effects, so manatong planning, and the patient will have an understanding on the drug regimen. And then your nursing diagnosis we have here. Okay, next. And then implementation. Okay, we'll just have to read this one. arrange for medical evaluation, monitor the patient, response to the drug, monitor for adverse effects of parent, monitor for the effectiveness of comfort of this drug. Now we'll go to the gastrointestinal protectant. So, available ani is your sucralfate. Okay, at naging ni Doc kanina, if na-release na, like, nakuha na dyan ang acids, will just to protect the mucus lining. Okay, next. So sucralfate forms an ulcer-adherent complex at duodenal ulcer site, protecting the sites against acid, against pepsin, and bile salts. So this action prevents further breakdown of the area and promotes ulcer healing. So this drug also inhibits pepsin activity in gastric juices, preventing further breakdown of proteins in the stomach, including the protein wall of your stomach. Okay, next. Okay. Your sucralfate is rapidly absorbed after oral administration, metabolized in the liver, exuded in the feces. It crosses the placenta and may enter the breast milk, just like any other drug. Okay, next one is your contraindication. So again, allergy ragyapon. And then it should not be given in those with renal failure or undergoing dialysis because of my build-up of aluminum may occur if it is used with aluminum containing products. So caution should be used in patients who are pregnant at lactating because of the potential adverse of the fetus or the neonate. Okay, next. Okay, the adverse effects. It can cause constipation. Is most frequently seen is due to because of these aluminum salts, and also your diarrhea, nausea, and indigestion. Okay, next. Okay, your clinically drug-to-drug interaction. If aluminum salts were combined with sulfate, there is a risk of high aluminum levels and aluminum toxicity because sulfate contains aluminum due to small amount of aluminum absorbed with oral intake. It can cause aluminum accumulation. So, munang magka-aluminum toxicity ka, ma-accumulate ang imong aluminum. And then in addition, if phenytoin, fluoroquinolone, and antibiotics or penicillamine is combined with sucralfate, decreased serum levels and drug effectiveness may result. Okay, next. Okay, what are nursing considerations? Of course, we have to assess again for any contraindications or cautions like any history of allergy to that drug, to sucralfate, and to prevent hypersensitivity, we have to perform a physical examination to establish baseline data. Next. We have to inspect the skin for color and evidence of lesions, maybe it and indicate an adverse effect of the drug. Assess the patient neurological status, examine the abdomen, and we have to auscultate the bowel sounds. Next, assess mucous membrane status and monitor the results of any laboratory tests such as your renal function. And then we have here several nursing diagnoses and then planning. Okay, and then we have implementation. So you have to monitor the patient while we administer that drug. And then we have yes. Okay, next. Okay. Next is your prostaglandin. The available drug in this is the misoprostol. So we know that misoprostol is an abortive patient. Okay, it would be cautioned with its use in women who are pregnant. Okay, next. So prostaglandin E1 inhibits gastric acid secretion. So yung inhibit ang gastric acid secretion and increases bicarbonate and mucus production in the stomach, thus protecting the stomach lining. So misoprostol is primarily used to prevent enzyme-induced gastric ulcers in patients who are at high risk for complications from a gastric ulcer. Okay, patients, we have ulcer like elderly or debilitated patients, patients with a past history of ulcer. Okay, next. Then it is given orally. It is well absorbed in your GI tract, metabolized in the liver, and excreted in the urine. So misoprostol crosses the placenta and enters the breast milk. Just like any other drug. Okay, it is a contraindication. So, contraindicated allergy to any part of the drug to prevent hypersensitivity. Of course, women of child bearing age should be advised of negative serum pregnancy test within 2 weeks of beginning treatment to make sure na before we're going to administer this drug. And also, In addition, they should be instructed to use barrier contraceptives during therapy. So caution should be used during lactation because of the potential for adverse effects of the newborn. Okay, caution also is desired in patients with hepatic or renal impairment. Okay, next. Okay, adverse effects. So, associated with GI effects, mga nausea, diarrhea, and you have the genitourinary effects related to your actions of prostaglandins and the uterus. You include miscarriages, excessive bleeding, spotting, cramping, hypermenorrhea, and dysmenorrhea. Hypermenorrhea is your prolonged menstrual bleeding and other menstrual disorders. Okay, next. Okay, what are our nursing considerations? Of course, assess again for possible contraindications, history if naba siya allergic sa salbutamol, perform physical examination. Next, examine the abdomen and then perform a pregnancy test para mo make sure na to make sure that the woman is not pregnant. Okay? Then monitor the results of laboratory tests. Okay, next. And then we have here our nursing diagnosis, and then planning, and then the implementation. Okay, so let's lead that one. Okay, next is the digestive enzyme. So these are the substances produced in the GI tract to break down foods into usable nutrients. Example, pancreolipase, there's saliva substitute. So what are these? Next. Okay, so lava substitute contains electrolytes and carboxymethyl cellulose to act as a thickening agent in dry mouth conditions. So this make the food bolus easier to swallow and begins the early digestion process. So na-discuss na kanina the importance of saliva to start the digestion. So saliva substitute helps in conditions that result in dry mouth. For example, with patients with stroke, radiation therapy, chemotherapy, and other illnesses. So the pancreatic enzymes are replacement enzymes that help the digestion and absorption of fats, proteins, and carbohydrates. Okay, next. Okay, what is a pharmacokinetic? So it is a available solution. It works when applied to the mouth. Pancreolipase is available in capsule, delayed release capsules, powder, and tablet form, and is thought to be processed through normal metabolic systems in the body. Little is known about its pharmacokinetics lang. Okay, next. Okay, saliva substitutes contraindicated in the presence of known allergy gyapon. Okay, to prevent hypersensitivity, it should be used cautiously in the patients with heart failure, hypertension, or renal failure because there may be an abnormal absorption of electrolytes, including your sodium, leading to increase in your cardiovascular load. So pancreatic enzymes should not be used with known allergy to the product or to pork products to prevent hypersensitivity reactions. So in addition, both saliva substitute and pancreatic enzymes should be used cautiously in pregnancy and lactation because of the risk for adverse effects. So murag tanan man diha dagay nga drugs, almost drugs, we have to be very cautious in pregnancy and lactation. Okay, next. So what are the adverse effects? So most commonly seen with saliva substance involved in complications from abnormal electrolyte absorption, such as increase in levels of magnesium, your sodium, or potassium. So that most often occur when pancreatic enzymes are related to GI irritation. Okay, next. And then what are our nursing considerations? Of course, again, we have to assess if the obviously history of allergy of any drugs and or to any pork products. And then next, perform physical examination, perform an abdominal examination, monitor mucous membrane to assess for their condition and for any indication of the need for saliva substitute. Okay, next. And then assess for cardiopulmonary status, okay, including your blood pressure, monitor the results of laboratory tests. And then we have here our nursing diagnosis. Okay, next. And then the planning, implementation. So para na siya tanan, you have to monitor, and then administer. So para sa evaluation, we have to monitor for patient response to the drugs, monitor for adverse effects. Okay, so and evaluate the effectiveness of the teaching plan. Okay, so that is all for the drugs affecting the gastrointestinal secretions. Thank you.
So, unsa na may sunod ron? Mas
So,
motility, sige. Para ni sa mga gakalibanga o para sa mga
investigation.
gitubol. Sige.
Okay, so hello, Doc. Hi, everyone. I am Chon, and for today's presentation,
So,
I will explain.
before that, ana lang niya. With regards to conditions affecting motility manggod, ana lang, kung sobra ra kayo ang imong paglihok sa tiyan kay magkalibanga man ka, dili ma-absorb bagod ang water kung sobra ra ang lihok sa inyong tinai. So, you have to slow down the movement of the GI tract, if that is the case. Pananglitan po kung tinera po kayo ang lihok sa imong mga GI tract, mga cause siya constipation, kay lagi, gisubrahan ra po niya absorb ang water sa imong mga large intestine kay hinay na kay nga lihok. So, iyo po ipapasta sa gamay. But here, kuan palitan if the kalibanga is caused by kanang bacteria, mayon ana, please, again, have to emphasize this, please, ayaw ninyo og ipahinay, palihok inyo nga tinai. If, again, infectious types siya, like bacterial infection, mayon ano, nga nakakos sa inyong kalibanga, sa inyong diarrhea, ayaw og ipahinay og lihok ang inyong tinai. The reason ana is, kung ipahinay niyo og lihok ang inyong tinai, you do not increase the excretion of the root cause sa inyong diarrhea. So, mag-concentrate ra ang inyong bacteria sa inyong tinai nga may nakakos sa kalibanga. Okay? Aside, makaingon mo nga, ay, wala na akong kalibangan na ayo na to. But then, wala mo na ayo. Inaaraman dito ang bacteria. Wala ninyo i-expel ang bacteria. Aside from that, this bacteria can be absorbed sa iyong GI tract. Once it is absorbed, it may cause septicemia. So, if ever ang cause niya is infectious type, ayaw ipahunong o kalibanga ang pasyente. Just support the patient sa iyang fluid kung magsige siya kalibanga. Fluid replacement is really very important. Okay? So, nahitabo naman gud nga muinom dahil og lumutil. Parang kalibanga inom dahil lumutil. Wala niya una-unaan nga ang hinungdan dahil sa kalibanga is an infectious process. So, wala niya iyang gipahunong palihok. So, na-absorb ang mga bacteria sa mga GI tract. It causes septicemia. Namatay ang pasyente, hindi kasundan. Okay? So, continue.
Okay, so for the glossary of key terms, this can be found kaning mga words sa atuang discussion. For antidiarrheal, these are drugs that blocks the simulation sa atuang GI tract, which will result into decreased activity and increased time for absorption sa nutrients and water. For bulk stimulant, this is one of the category sa ato ang laxatives, which increases in bulk frequently by osmotic pull of fluid into the feces. So the increased bulk stretches the GI wall, causing stimulation and increased GI motility. For cathartic dependence, this is the highlight of the adverse effects at ang laxatives if we overuse the use of laxatives. This can lead to the need for strong stimuli to initiate movement in the intestines. Local reflexes become resistant to normal stimuli after prolonged use of harsher stimulants, leading to further laxative use. And then chemical stimulants, which is also one of the categories of the laxatives, which stimulates the normal GI reflexes by chemically irritating the lining of the GI tract, leading to increased activity in the GI tract. And for constipation, as na-discuss ni Doc kanina, mo na siya agkato ang slower than normal evacuation sa atong large intestine. So pag slow, this can result anang increase ang iyang absorption from the feces and mo nang maglisod na taog kanang kalibang. Then diarrhea, more frequent than normal bowel movements, meaning the kalibanga ta, often characterized as fluid-like and watery because not enough time for absorption is allowed during the passage of food through the intestines. Then lastly, it is the lubricant, which is one also of the categories atong laxatives, which increases the viscosity of the feces, making it difficult to absorb water from the bolus and easing movement of the bolus through the intestine. So we are now in the drugs. So these drugs that will affect GI motility works in different ways. So for example, you have constipation.
So if you have constipation, the food may move too slowly through the digestive tract, which gives the colon or the large intestine too much time to absorb water from the waste, which dries out stool, making it hard in consistency and difficult to push out in the body. So unang pag constipated ta, lisod ikalibang tungod sa kagahi sa ato ang tae, mo nang maglisod ta og pagawas. Dugangan pa sa pagka-bloated sa atong tiyan og kasakit pod sa tiyan. So with the help of these drugs, mapa-speed up niya ang movement sa imong GI tract and might relieve your constipation. So muna siya isa ka way on how these drugs work. Next, drugs also are used to increase the tone of the GI tract and to stimulate motility throughout the system. Now, how does this drug affect the GI motility pag paspas na ang movement sa imo ang GI tract nga maoy makapa-decrease sa time for the absorption of nutrients, which can lead to loss of water and nutrients and discomfort of diarrhea. Well, these drugs help to solve the problem by decreasing the movement along the GI tract, which is the third way on how these drugs works. So the topics to be discussed, we have laxatives, including its categories: chemical stimulants, bulk stimulants, lubricants, and other laxatives. We also need to talk about gastrointestinal stimulants, antidiarrheals, irritable bowel syndrome drugs. So this is the site of action of drugs affecting your GI motility. So this can be found in the book. So please nalang ko og scan. Now, we are in the drug therapy across the lifespan. So these are the laxatives and antidiarrheal agents. So in children, laxatives should not be used routinely. Proper diet, including roughage, plenty of fluids, and exercise, should be tried first if a child has a tendency to become constipated. So, how does proper diet include roughage in vegetable foodstuffs, which aids the passage of food and waste products to the gut, prevents constipation, while dietary fibers increases the weight and size of your stool and softens it. So a bulky stool is easier to pass, decreasing your chance of constipation. Now, how does plenty of fluids help in treating constipation? Drinking liquids is a great way to get more water into the body, and staying hydrated is a powerful natural method for easing constipation. Extra water in the stool makes it softer and helps it to pass more smoothly. So in fact, being low on fluids is a common cause of constipation. Then how does exercise help in preventing constipation? Well, exercise helps by lowering the time it takes food to move through the large intestine. This limits the amount of water your body absorbs from the stool. Now, if laxative is needed, glycerin suppositories are the best choice for infants and young children. Lubricants can be used in older children, but harsh stimulants should be avoided. Children with encopresis, or sometimes called as fecal incontinence or soiling, this is the repeated passing of stool, which is usually involuntary. It typically happens when impacted stool collects in the colon and rectum, so the colon becomes too full and liquid stool leaks around the retained stool, staining underwear, or in Bisaya, nakakuan na ta, nakaigit. And however, are often given with senna preparations in or mineral oil in order to help them to evacuate the massive stool. Children receiving these agents should use them for only a short period of time and should be evaluated for potential underlying medical or nutritional problems if they are not able to return to normal function. Then loperamide may be the antidiarrheal of choice sa children older than 2 years of age if such drug is needed. Special precautions need to be taken to monitor for the electrolyte and fluid disturbance, and supportive measures taken as needed. So for the adults who use laxatives need to be cautioned not to become independent. Kasi mostly, again, one of the adverse effect ani nga laxative is the cathartic dependence. So ato lang siyang i-discuss later. So proper diet also and exercise and adequate intake fluid should keep the GI tract functioning normally. And if an antidiarrheal is needed, adults should be careful in carefully instructed in the proper dosing of the drug and monitoring of their total use to avoid excessive dose para dili sila ma-overdose or para dili ma-overuse ang paggamit nila sa laxatives. Now, the safety for the use of these drugs during pregnancy and lactation has not been established. So, use should be reserved for those situations in which the benefit to the mother outweighs the potential risk to the fetus. So, same lang ni sila sa other drugs po. A mild stool softener is often used after delivery. So, why is a mild stool softener gamitan man siya after delivery? So, the general level of tenderness that people experience after delivery can make them anxious about bowel movements. So, taking postpartum stool softener can help make bowel movements easier during this time. So, the drugs may enter breast milk and may also affect the G activity in the neonate. It is advised that caution can be used if one of these drugs is prescribed during lactation. So for older adults, they are more they are more likely to develop adverse effects like sedation, confusion, dizziness, electrolyte disturbances, fluid imbalance, and cardiovascular effects. So safety measures may be needed if these effects occur and interfere with the patient's mobility and balance. So older patients also may be taking other drugs that are associated with constipation and may need to prevent severe problems from developing. So older adults are more likely to have renal or hepatic impairment related to underlying medical conditions, which could interfere the metabolism and excretion of the antidiarrheal drugs. So the dose for older adults should be started at a lower level than recommended for younger adults. So the older adults should be monitored very closely and those adjustments should be made based on the patient's response. So these patients needed to be alerted to potential for toxic effects when using OTC preparations and should be advised to check with their healthcare provider for beginning any OTC drug regimen. So asylum product is the agent of choice with older adults because there is less risk of adverse reactions. So the patients needs to be cautioned to drink plenty of fluid after taking one of these agents to prevent problems that can occur if the drug starts to pull fluid or mag-start na siya absorb sa fluid while still in the esophagus. So the older adults should be encouraged to drink plenty of fluids, to exercise every day, and to get plenty of roughage in the diet. Many older adults have established routines such as drinking warm water or prune juice at the same time each morning that are disrupted with illness or hospitalization. These patients should be encouraged and helped to try to maintain their usual protocol as much as possible. Now we are in the laxatives. So these laxatives are also known as cathartic drugs. When we say cathartic, this means that it is a substance that eases defecation. Or sa definition dire, these are drugs used to stimulate movement along the GI tract and aid bowel evacuation. So this is the first category or the first kind of the laxatives. We have chemical stimulants. This directly stimulate the nerve plexus in the intestinal wall. So what will happen if um, the nerve plexus in the intestinal wall is directly stimulated? It increases or it causes an increased movement and stimulation of local reflexes. So these are the drugs under chemical stimulants. We have bisacodyl, cascara, castor oil, and senna. So for bisacodyl and for bisacodyl or dulcolax, it is the first drug under the chemical stimulants, and this directly stimulates parasympathetic nerves in the colon. So which so in result, this increases motility and secretions in order to help the stool come out. For so remember, ang katong gitudlo sa ato ana, if parasympathetic effect siya except sa 4, dito man nabilong ang parasympathetic effect sa GI motility. So motility and secretions. So ang kuan ana is increase siya. Mo nang ang imbisakodil if iyang i-stimulate ang nerve plexus sa kuan, uh, mo nang bisakodil if iyang i-direct stimulate ang parasympathetic nerves, increase gyud ang GI movement. Then cascara acts principally in large intestine by stimulating propulsive movements of colon through direct chemical irritation. So special consideration. It may have a slow, steady effect or may cause severe cramping and rapid evacuation of the contents of the large intestine. Patients should be advised of the possibilities and the need to maintain ready access to bathroom facilities. For the castor oil, it directly stimulates the nerve plexus in the intestinal wall, causing increased movement and the stimulation of local reflexes. So, special considerations, avoid frequent use to prevent constipation from GI tract exhaustion when there is no stimulus to movement. For Senna preparation or the Senocot, it works by irritating and stimulating intestinal cells, causing contractions, water influx, and bowel movement. For its pharmacokinetics, so most of these agents are minimally absorbed and exert their therapeutic effect directly in the GI tract. Changes in absorption, water balance, and electrolyte resulting from the changes can have adverse effects on patients with underlying medical conditions that are affected by volume and electrolyte changes. And castor oil, okay, you can just read on that in the book. For contraindications, chemical stimulants are contraindicated with allergies. So same lang sila sa uban nga drugs to prevent hypersensitivity reactions. And in acute abdominal disorder, including appendicitis, diverticulitis, and ulcerative colitis, contraindicated po siya because when increased motility could lead to rupture or further exacerbation of the inflammation. Laxative should be used with caution in heart block, CAD, or debilitation, which could affect by the decrease in absorption and changes in electrolyte levels that can occur. So use with caution during pregnancy and lactation. Why? Because in some cases, stimulation of the GI tract can precipitate labor, and many of these agents cross the placenta and excreted in the breast milk. Now, take note that castor oil should not be used during pregnancy. Why? Because its irritant effect has been associated with induction of premature labor. And magnesium laxatives can cause diarrhea in the neonate if it is used in lactation. So for the adverse effects, GI tract, diarrhea, abdominal cramping, nausea, CNS dizziness, headache, weakness, and sweating, palpitations, flushing, and even fainting occur after laxative use, and these effects may be related to sympathetic stress reaction to intense neurostimulation of the GI tract or to the loss of fluid and electrolyte imbalances. Now, this is the highlight of the adverse effects in using laxatives. It is the cathartic dependence, which happens if you abuse the use of laxatives. This can lead to the need for strong stimuli to initiate movement in the intestine, and local reflexes become resistant to normal stimuli after prolonged use of harsher stimulants, leading to further laxatives. And without this stimulation, the GI tract does not move for a period of time, which could lead to constipation and drying of the stool and ultimately to impaction. So mo nang siguro pod sa uban it is a generalize na ko siya if mag-abuse gyud ta na agid tay kanang nadyo mo resulta nga mas intense and mas grabe pa nga consequence. So mo nang in using laxatives, take note nga dili na to i-abuse in order nga wala pud tay negative nga consequence nga mahitabo sa tuang lawas. So for the clinically important drug-drug interactions, it is not advisable to take laxatives with other prescribed medication because laxatives increase the motility of the GI tract and some can interfere with the timing or process of absorption. So if ever na you are taking laxatives and also other medications, the administration should be separated by at least 30 minutes. So this is the prototype summary of castor oil. You can just scan this on the book. Now, we are in the book stimulants. So these stimulants are also called as mechanical stimulants, which are rapid-acting, aggressive laxatives that cause fecal matter to increase in bulk. So when we say bulk, kanang bulto, kanang dagko. So it increases intestinal fluid content, stimulates local stretch receptors, and activates local activity to increase the GI motility. So for the bulk stimulants, these are the agents. We do have this lactulose, magnesium citrate, magnesium hydroxide, magnesium sulfate, polycarbophil, polyethylene glycol, polyethylene glycol electrolyte solution, xylem, sodium picosulfate, or magnesium oxide. So for lactulose, it is a saltless osmotic laxative that pulls fluid from the venous system into the lumen of small intestine. Magnesium citrate and magnesium hydroxide is same lang sila, so they are milder, slower acting laxatives. So a saline push is used to bring fluids into the GI tract. Magnesium sulfate works by exerting a hypertonic pull on the mucosal wall, causing fluid to enter the intestinal contents. Polycarbophil and also xylem, they are naturally occurring substances that forms a gelatin-like bulk from intestine contents. So these agents stimulates local activity while being gentler and less irritating than many other bulk stimulants. So polyethylene glycol or the Miralax and also the polyethylene glycol electrolyte solution. So these are hypertonic fluids that contains various electrolytes and pull fluid from the intestinal wall to increase the bulk of the intestinal contents. Then lastly, it is the sodium picosulfate with magnesium oxide. This acts both a stimulant and bulk laxative and is used to cleanse the colon prior to colonoscopy procedure. So for its pharmacokinetics, all these drugs are taken orally and they're directly effective within the GI tract and not generally absorbed systematically, rapid acting causing effects of the GI tract as they pass through the GI tract. So for the contraindications and cautions, these are just the same sa chemical stimulants, but bulk laxatives are also contraindicated with allergy to any component of these drugs to prevent hypersensitivity and laxatives. Okay, the same lang sila sa chemical stimulants na contraindications. For the adverse effect, um, ang highlight, the same lang ang GI tract, CNS, and also the sweating, but patients must use caution and take bulk laxatives with plenty of water. Because if only a little water is used, the laxative may absorb enough fluid in the esophagus to swell into a gelatin-like mass that can obstruct the esophagus and cause severe problems. So this is the variety of adverse effects and toxicities associated with the drugs. You can just scan it in the book. For the clinically important drug-drug interactions, okay, the same lang siya sa um, chemical stimulant na ang administration good sa laxatives kay should be separated by at least 30 minutes. And for magnesium salt, an increase of neuromuscular blockade when using non-depolarizing neuromuscular junction blockers. So if this combination is used, the patient must be closely monitored and appropriate life support provided. So this is the prototype summary of magnesium citrate. You can just scan it in the book. So now we are in the third category of the laxatives, which is the lubricants. So lubricants help the intestinal contents move more slowly, and as a matter of fact, by just using lubricants, you can defecate easier without stimulating the GI tract movement. So
Last naman yung lubricants, no?
yes, doc, sa laxatives, doc.
Okay. Sige, continue.
So it does facilitate the movement of the bolus. So patients with hemorrhoids and those who have recently had rectal surgery may need lubrication of the stool. So these are the drugs under the lubricants. We have docosate or docolace, glycerin, and mineral oil. So for the docosate or docolace, it has a detergent effect on the surface of the intestinal bolus, causing an increase in fat-water admixture and softer stool. Glycerin is a hyperosmolar laxative used in suppositories to gently evacuate the rectum without causing systemic effects higher up in the GI tract. Mineral oil It is the oldest laxative and it is not absorbed, instead forms a sleek coating around the contents of the intestine. So when intestinal bolus is coated with
Okay, as the name implies, lubricant siya. Mupahanlas ra siya sa agianan. Pareha bubutangan ni mog oil ra para mo hanlas. So that is a lubricant. Sige, next.
okay, so for the pharmacokinetics, you can just scan it in the book. For the contraindications, the same lang siya sa chemical book stimulants since they are in the same category. They are in the same and they are all laxatives. For the adverse effects, the same lang siya. And clinically important drug-drug interactions, frequent use of mineral oil can interfere with absorption of fat-soluble vitamins A, D, E, and K. Because mineral oils, given orally man siya, and it coats the bowel and softens the stool mas man, thus easing the latter's passage. So mineral oil, di good siya digestible. So indigestible siya and it is not absorbed sa ato ang intestine. So kuan, it its prolonged use may cause vitamin deficiencies. However, because it carries fat-soluble vitamins out of the digestive system, which will then result to inhibiting their absorption. So this is the prototype summary of the mineral oil. You can just scan it in the book. Okay, we are now in the other laxatives. So these are the two drugs. Hanis sila kabuok that do not fit into the categories usually used for laxative, but they have been approved for the treatment of constipation. So the first drug is the methylnatrexone or the Relistor. It is a selective antagonist to opioid binding at the muscarinic receptors. So for the pharmacokinetics, you can just read on that. And adverse effects, abdominal pain, flatulence or farting, nausea, dizziness, and diarrhea. Naloxegel is the second drug na nabilong sa other laxative. So mechanism of action, muscarinic receptor opioid agonist. So indications, treatment of patient with opioid-induced chronic constipation, and in adults, chronic and non-cancer pain. So you can just read on the pharmacokinetics and the adverse effect. So for the nursing considerations of using laxatives, okay, the same lang siya sa other drugs pod nga you need to assess for possible contraindications and cautions, history, perform physical examination, inspect the skin for rash, and assess for, okay, the same lang sila pod. The nursing diagnosis, also you can just read on that, including the planning and implementation, of course. So for the evaluation, okay, we are now in the gastrointestinal stimulants. So, when we say stimulants, increase gid ni siya, di ba? Gister ni Doc na ang effects sa parasympathetic. So, kani ang mga drugs kay it stimulates parasympathetic activity or make the GI tissues more sensitive to parasympathetic activity. So, unsa gali toy effect basta parasympathetic then sa gastro pa jud siya or sa atong GI, it increases the GI motility and also the secretions. So these are the drugs under the GI stimulants. We have dexpanthenol, metoclopramide. So for the dexpanthenol, it works by increasing acetylcholine levels and stimulating the parasympathetic system. For indications, prevention of intestinal atony or loss of intestinal muscle tone in post-operative situations in adults. So pharmacokinetics, you can just read on that. And metoclopramide or the Reglan, it works by blocking dopamine receptors and making the GI cells more sensitive to acetylcholine. So for the indications and pharmacokinetics, you can just read on that in the book. For the contraindications, GI stimulants should not be used in patients.
Balika timo metoclopramide kani mo ni say this is marketed as your Placil or Reglan. Okay? Para ni siya kana magsuka-suka bitaw ka mo ni siya gamiton. Okay, it blocks your dopamine receptors. It is a dopamine receptor blocker. That's as simple as that. Okay, so parang dili kay ka active. Okay, dili ka magsuka-suka. Sige, next slide.
Okay, so for the contraindications, GI stimulants should not be used with patients with history of allergy to any to any of these drugs. This is to prevent hypersensitivity, just like other drugs, and with any GI obstruction or perforation, which could be exacerbated by GI stimulation. And they should be used with caution during pregnancy or lactation, and only if the benefit to the mother clearly outweighs the potential risk to the fetus or neonate. So for its adverse effect, nausea, vomiting, diarrhea, other adverse effects, so you can just read on that. It is found in the book. For the clinically important drug-drug interactions, metoclopramide has been associated with decreased absorption of digoxin from the GI tract. So patients taking this combination should be monitored carefully. So when combined with metoclopramide, i-combine siya sa cyclosporine, this will result into decreased immunosuppressive effects and increased toxicity.
Sige,
So
next
this
slide.
combination should be avoided.
Next slide.
So for the nursing considerations sa gastrointestinal stimulants, these are just the same pod sa laxatives. Nursing diagnosis planning, you can just read on that. For the implementation, administer at least 15 minutes before each meal at bedtime. So the rest, you can just read on that in the book. For the evaluation, okay. Now we are in the diarrheals. So these antidiarrheals block the stimulation of the GI tract for symptomatic relief from diarrhea. So these are the antidiarrheal agents. Siyempre, ang iyang indication gud ani is to treat diarrhea. For the drugs under ani bismuth subsalicylate, clofelimer, loperamide, which is very familiar pod sa atua, opium derivatives. So for the combination of antidiarrheal products and traveler's diarrhea, you can just scan it in the book. Sabotable ra ni siya. Also, the critical thinking scenario pod. Okay, now let's move on to the antidiarrheal agents. So this bismuth subsalicylate or the Pepto-Bismol, it directly acts on the lining of the GI tract to inhibit local reflexes. So these are for its indication and pharmacokinetics, you can just read this on the book. Clofelimer or the Fulizag, it is the chloride channel in blocker or inhibitor. For the indications and pharmacokinetics, you can also read that on the book. Loperamide or Imodium, mo ni siya ang familiar pod sa atua or sa akua, which directly acts on the muscles of the GI tract to slow the activity. For the indications and pharmacokinetics, you can just read on that. Opium derivative or the paregoric, it acts on CNS centers that cause GI spasm and slowing. So for its indication, short-term treatment for cramping and diarrhea. For its pharmacokinetics, you can just read on that on the book. Contraindications and cautions. It should not be given to anyone with known allergy. This is to prevent hypersensitivity reactions. Caution should be used in pregnancy and lactation just like other drugs. Care should also be taken in individuals with any history of GI obstruction, acute abdominal conditions, or diarrhea due to poisonings or with hepatic impairment. So for the adverse effects, GI tract, okay, you can just read on that. For the clinically important drug-drug interactions, so drug interactions vary depending on the antidiarrheal agent. So, okay, you can just read on that. So this is the prototype summary of the loperamide. For the nursing considerations for patients receiving antidiarrheals, these are just the same sa assessment pod sa ato ang laxatives. Okay, nursing diagnosis, you can just read on that. Also the implementation and evaluation. So we are now in the irritable bowel syndrome. Well, we do have this certain drugs po nga makatabang sa pag-treat ani, but we'll try to define first what is irritable bowel syndrome. So this is a very common condition that affects our digestive system. So it causes symptoms like stomach cramps, bloating, diarrhea, and constipation. These tend to come and go over time and can last for days, weeks, or months at a time, and it's usually a lifelong problem. So it It strikes 3 times as many women as men and reportedly accounts for half of all referrals to the GI specialist. So, okay, so you can just read on this. Now, these are the drugs that are said to be used in treating IBS. So we do have allositron or lotronex, mechanism of action, serotonin 5-HT antagonist. So you can just read on the text in the box, makita rin siya sa book. Dayon, lubiproston or the amitiza, mechanism of action, chloride channel activator, indication, pharmacokinetics, and adverse effect. You can just read this on the book. Also, the hyoscyamine, anaspaz, which is an anticholinergic agent that was found to decrease GI spasm, was approved in 2001 as an adjunctive therapy for the treatment of IBS. Support and symptomatic relief remain the mainstay of treating this order. So, stress management and a consistent relationship with the healthcare, okay, you can just read on that.
Sige, next na lang na antiemetic. Sige. Ah,
Wait,
kajat. Chapter 59 is the last chapter.
Yes, Doc. Good morning.
Okay. Since this is the last chapter and our exam will be on Wednesday pa, we'll discuss this on Monday. Okay?
Okay,
We'll,
Doc.
wala
Okay,
pa
Doc.
ding, okay. So,
Okay,
we'll
Doc.
discuss chapter 59 Monday at 6 p.m. Okay. Bakante ka naman ng 6 to 7, di
Okay,
ba?
Doc. Thank you, Doc.
Yes, Doc.
Yes,
Okay.
Doc.
Sige. We'll discuss this on Monday. Anyway, last naman yung chapter. Sige, yeah. Sayon na po ning antiemetic dali ra kayo. Okay. Sige. If there are any questions regarding the topics, please feel free to message at ang group chat. If there anything you wish to ask. Ana lang ni sa atong GI gani, as with all the other diseases, we go for the root cause. Usa may cause sa iyang kalibanga. Cause sa iyang kalibanga is infectious positive to treat the infection. But aside from treating the infection, of course, if you haven't known the cause, the exact cause, it's imo po siyang symptomatically treated. Example, kung sakit kayo sa panalihan, nagkala mong pinalibro, obviously. Kung palitan, kusog ay kang gawas yung tayo di ay hindi pahulong yung paggawa sa tayo. If, again, only if you know nga, pili infectious na type siya. Pero ng mga travelers diarrhea lang, mga allergic reaction, that you can go with anti-motility agents para di ka magsigig kalibanga. That you can do with mga lumutil, mga inana. Pero again, if it is bacterial cause, ayaw taon ipahulong o gawas sa iyong tayo. Mas may na magawas na sila kay manggawas po ng mga causative agent. You just have to symptomatically give fluid replacement to the patient. Very important fluid replacement. This is number one. With regards to kalibanga, even with constipation, you have to give a lot of water. Also, para humuk yan tayo and increase motility. By the way, you do not give motility agents or motility enhancing agents or what you call prokinetic agents. That's what you call it. You don't. Kinetic means movement. Prokinetic means for movement. So you do not give prokinetic agents for obstruction. If wala siya kalibang tungod na obstructed ang iyang agianan sa iyang tahi, you do not give prokinetic agent. Why? Dunay chance nga mo buslot imong tinai kay mulihok man mayo imong tinai. Pag lihok imong tinai, iyang i-move imong tahi pagawas. But then ano obstruction, so dito sa site obstruction, muburot siya maayo. Kay dito nagipush tanan until mubuto ang imong tinai. So, obstruction na yun obstruction, you do not give prokinetic agent. Mao na ang gisigig balik-balik ganyan sa report. Obstruction, you do not give prokinetic agent. Okay, sige. You may go now.
thank you, Doc.
Thank you, Doc.
Bye.
Thank you, Doc.
Goodbye. Thank
Okay.
you,
Thank you,
Doc.
Doc.
Thank you, Doc. Thank you, Doc.
Bye.
Thank you, Doc.
Thank you, Doc. Bye, Doc.
Thank you,
Thank you,
Doc.
Doc.
Salamat, Doc. Goodbye.
Thank you, Doc. God bless.